Good evening all. It gives me immense pleasure to welcome you all to the fourth webinar organized by the IRA Kerala chapter. All the previous three webinars were a big success, and today we have two very eminent speakers. The first talk will be by Dr. Remesh Bhasi, President of IRA Kerala chapter. He'll be talking on telemedicine in rheumatology, which is a very important topic, especially at this moment, when we are facing the COVID pandemic. And the second talk will be an update on scleroderma by Dr. Madan Mohan. So the meeting will be moderated by Dr. Patmanabha Shenai from Cochin and Dr. Anup from Calicut. Now I invite Dr. Shenai and Dr. Anup to take over the proceedings.
Thank you, Jayachandran sir, and it's a pleasure and honor to invite Dr. Remesh Bhasi, who is President of Indian Rheumatology Association Kerala chapter, and also one of the mentors to all of us. He's like a brother. He tells us how to mentors us and guides us in every aspect of every IRA Kerala chapter's progress, not only professionally and personally, also helps us a lot of ways. And he's going to speak to us on very most relevant topic, teleconsultation rheumatology. Teleconsultation, all of us have tried teleconsultation in different ways and has been decreased the not only our risk to exposure to patient to COVID, and also help the patients so that they can sit at home and consult the doctor at their leisure without risking their getting any COVID-19. So it has been a huge revolution. We have one of the silver lines of the COVID pandemic is we have learned webinars, one, and another one is teleconsultation has become legalized. So to speak to us and share his experience, Dr. Remesh Bhasi is here. Over to you, sir.
Thank you, Shanai. Good evening, dear friends. What started off as a mysterious disease in Wuhan in December 2019 was soon identified as COVID-19, and it gradually spread to the whole world. WHO declared COVID-19 as a pandemic on March 11. One of the various strategies by which the countries tried to contain the pandemic was by locking down and making people confined to their own home. Government of India imposed the lockdown on 25th of March, which lasted through 4 phases till May 31st. Metros, otherwise rustling with heavy traffic, came to a halt and became empty. Stay home, stay safe slogan caught off, and people remained at home, which was enforced by the authorities. The pandemic had a huge impact on our personal, social, and professional lives. You may recall the confusion we went through in early part of April. Our consultation drastically reduced number of consultations. New COVID protocols by the hospitals restricted entry of patients except for emergencies. Patients themselves were scared to come to the hospital, but you can't lock down diseases. You can't lock down patients. Patients' medical needs must be attended to. With the travel ban and the restricted mobility, the only way this is possible is through telemedicine. But what is the scenario of teleconsultation in India? Telemedicine consultation has been in practice since 2000. But it was not clear whether it was legal or not. In fact, 2 states, the Karnataka State Medical Council and Travancore Cochin Medical Council, that is our council, issued warnings against telemedical consultation at some point of time. And it was generally believed that telemedicine is not for new patient consultations, and it is good for only for follow-up consultations. What about the medico-legal issues? Nobody was sure. And consultation, can you charge a consultation fee for the teleconsultation? Nobody was sure. And this is the newspaper item which came in September 2018, following the Bombay High Court verdict on a couple of doctor couples who was convicted for negligence, medical negligence while doing telemedicine. So the question was, telemedicine has no legal background, and the IMA took it up, and but even then there were no official guidance even at that point of time. But the government of India anticipated that the only way the medical advice can be given in COVID era is through telemedicine. So promptly on the day of the lockdown itself, 25th March itself, they came down with a telemedicine practice guidelines for RMPs, that is registered medical practitioners. The Board of Governors in supersession of Medical Council of India, you know that Medical Council had been quashed by that time, and the Board of Governors were in supersession at that time. They issued the telemedicine practice guidelines, and the National Medical Commission came into place on 25th of September, and now this is a part of guideline. This guideline has become a part of NMC as well. So what does the amendment mean for doctors? Now, the teleconsultation is perfectly legal in India. First, or new line consultation is permissible. You can charge same fees as in physical consultation, and your online prescription is legal. But remember that any violation of guideline is considered as a misconduct. And with the present guideline, it is, they have not specified any time period, but it's believed that your records have to be kept for at least 2-3 years, because it's, the NMC is going to come up with a modification of guideline probably in the next 3 years' time. Now, what does the amendment mean for patients? They can hold doctors accountable. And violation of guidelines give patients avenue to make compliance. And the interesting point is patients are responsible, or patients, accountable for the information provided. And according to the guideline, I'm trying to discuss some relevant points of the guidelines. And in the guideline, what they have specified, these 7 elements have to be considered before any telemedicine consultation. And I will go through it each in brief. Context, whether you have to decide whether this is what the patient you are seeing is appropriate for a telemedical consultation. And the identification of the patient and the doctor is a must. And the mode of communication, whether it's going to be audio, video, text consultation, has to be decided. And consent is absolutely essential. And the type of consultation is important. Why it's important, I will come later, whether it's a new consultation or a follow-up consultation. And the last 2 parts is the most important part, patient evaluation and patient management. Now, the first point, the telemedicine should be appropriate and sufficient as per the context. Let us take an example of a case of rheumatoid arthritis on follow-up. You have seen the patient 3 months ago in your clinic, and the patient, you have prescribed a combination of DMARDs. Patient is doing well, and you are going to see that patient on as a teleconsultation, as a follow-up. This is an ideal case for a telemedical consultation. So, well, go ahead, no problem. There is everything, all you have to do is just assess the disease activity and decide on medication, and you can issue a prescription. But look at this scenario, next scenario. Rheumatoid arthritis patient with sudden onset of shortness of breath. This can be due to so many reasons. This can be a pneumonia secondary to undiagnosed infective exacerbation of ILD, or it could be a patient might have had an MI and it could be in left ventricular failure, or patient might have had a pleural effusion or even a pneumothorax. You can't deal with this patient through telemedicine. So you have to decide whether this is an appropriate case for a telemedicine. That responsibility is yours before you start your telemedicine. And patient identification is mandatory for first consultation. Most of this platform, digital platforms, take care of that, and they insist that the patient identity is verified. And one of the important features, a doctor should identify himself to the patient, and his qualifications, credentials, registration number, etc. should be displayed. And also there should be some means by which the patient can check the credentials of the doctor. Now, the mode of consultation can be video, audio, or text. You can use multiple technologies. And for example, you can start with a digital platform. And if the internet connection, if there are some issues with the internet connection at the patient's end, you can change to WhatsApp video call. And then you can issue the prescription through an email. So you can use multiple modalities, multiple technologies can be used here. You can use a landline, mobile phone, otherwise internet-based digital platforms, all these can be used. WhatsApp, Messenger, Skype, email, all these modalities can be used for telemedicine consultation. And patient consent is very important. It's implied when the patient requests for a telemedicine consultant, that consultant is implied. However, if a healthcare worker or a caregiver or other registered medical practitioner initiate the consultation, the explicit consent is required, and you need to get the consent from the patient, and it has to be recorded in your notes. Type of consultation could either be first consultation or the follow-up consultation. This distinction is important because the prescription you can give depends on whether it's a first consultation or a follow-up consultation. Even if you had seen the patient earlier, and if 6 months have elapsed, it is considered as a new patient consultation, as a first consultation. If you are seeing the patient for another new problem, that is also considered as a first consultation. Follow-up, obviously, if you are seeing the patient within 6 months, that is a follow-up consultation. The exchange of information for evaluation. This is an important part in telemedical consultation. Why? You must remember that patient is responsible for the accuracy of information. But this doesn't mean that you don't have that responsibility. I'm going to take two scenarios here. Suppose the patient, one of your patients was diagnosed as tuberculosis and he was started on ATT. And then he developed polyarthralgia. You are seeing that patient with polyarthralgia. But patient is not divulging the history that he was recently diagnosed as tuberculosis and he is on ATT. And when you see the patient, he has classic polyarthralgia, you do some investigation, you see a low titer rheumatoid factor, you start the patient on methotrexate or hydroxychloroquine, what are disease modifying drugs, and the patient develops complication later on. You cannot be accounted for the patient responsibility to divulge that information. But at the same time, it is your responsibility to note that the patient past medical history, the present medication should be noted down in the prescription. So you can't actually divulge this responsibility, but at the same time, if the patient is not divulging that information, you may get away with that. Another scenario, suppose one of your patient who is on lupus nephritis, he is on Aster and he is being treated with by another rheumatologist. And he develops sudden onset of acute MTP pain, and you diagnose it as acute gout. You start the patient on colchicine, followed by allopurinol or febuxostat. Patient goes into bone marrow suppression. But the patient didn't tell you that he has lupus nephritis and he was on Aster. But it's your responsibility to take a detailed history about other medical condition, other prescription. And these 2 points to be kept in mind. So exchange of information is a really complicated matter in telemedicine. And you have to maintain the same standard of care as you do in an in-person consultation. Let us take the example of an SLE patient on your follow-up. You know the patient, she had been in your follow-up for so many years and you are familiar with her medication. And then she comes in a teleconsultation and tells you that she has got a pain in the right leg, but she climbed so many, a few stairs on that the previous day, and she thinks probably it's because of that. And you also feel that, oh, okay, it could be a mechanical pain. But actually, patient had a DVT of the right leg at that time. Remember, the guideline clearly says that teleconsultation took place over a mobile app or email or telephone cannot be taken as a defense by a doctor against an allegation of medical negligence. If that patient with the DVT develops a pulmonary embolism and runs into complication, you are going to be held for medical negligence. Because It is the registered medical practitioner's responsibility to take all efforts to gather sufficient medical information about the patient's condition before deciding on a diagnosis or a treatment. And another important point here is, if a physical examination is critical for further evaluation, you should abandon online consultation and should arrange an in-person consultation. There are a few scenarios in rheumatology. For example, if you are seeing a patient with polyarthralgia, constitutional symptoms, and you elicit the history of claudication symptoms, and you consider the possibility of aortoarthritis, you know that you have to check the BP, you have to check the pulse. So a physical examination is essential. You can't proceed with the new patient consultation at that, consultation at that time. You have to insist on an in-person consultation. An elderly man coming with a left wrist pain and swelling of few days duration. It's a monoarticular arthritis. It could be gout, it could be pseudo gout, it could be septic arthritis. But you need to make sure that you aren't missing a septic arthritis. And you cannot go on with your teleconsultation. You need to clarify these points and make sure that you are not missing the diagnosis here. And all types of digital ischemia could be due to vasculitis, could be due to APS, and all the types of digital ischemia. I think it's better to avoid teleconsultation and make sure that the patient is being seen in your clinic. And all rheumatoid arthritis patient, you know the patient very well. You know that, but if they present with acute systemic symptoms, better to change to an in-person consultation. Polyarthralgia with so-called red flag symptoms like fever, weight loss, and loss of appetite, these symptoms and skin rashes, be very wary of these symptoms along with polyarthralgia, and don't go on with the teleconsultation. Make sure that you see the patient in your clinic or arrange for the provision, for the same. And coming to the management, it's once you see the patient, once you make a diagnosis, okay, you can issue a prescription. In actual in-person consultation, that's it basically. But here the guideline insists on the importance of counseling and health education. You need to make sure that if you are going to write a prescription of hydroxychloroquine, you need to ensure that you need to advise the patient about the ophthalmology evaluation, whatever is indicated. If you are writing a prescription for a steroid for a short period of time, you need to clearly explain to the patient that how to take, what all complications to be expected, and you should counsel the patient. If a patient requires a physio, that should be advised appropriately. And remember, health education is an important part. The guideline says that you have to do that. And suppose you need to educate the patient about the disease itself, but the other public health issues, especially COVID-19 at the present time. And I said, the guideline has issued some permissible drug list based on the type and mode of consultation. And the list of drugs that can be given, whether it's an audio consultation, video consultation, we can give that. But listed drugs are to be given, especially has to be followed by a video consultation. And the follow-up continuation of medication, these lists, you need to know the list of medication which can be given as a first consultation or a follow-up consultation. But you must also be aware of certain prescription at whatever stage you cannot issue through a teleconsultation. This is prohibited. These are all scheduled extracts which coming under the Cosmetic Act and rules. Any narcotic psychotropic substance cannot be prescribed through teleconsultation. And look at this point, the last point. Anti-cancer drugs, narcotics, morphine, codeine cannot be prescribed online. So list of drugs, any over-the-counter, drugs, OTC, that, you are familiar with all the medication. This can be prescribed either through a telephone, video, there's no problem with that. But the list of medication, certain medicines you cannot initiate. As for example, the diabetes, there are limitations on what you can start for the asthma, etc. But if you are seeing a follow-up medication, you can add these medicine. So you need to be aware of what all medicines you can prescribe on a teleconsultation. And in a rheumatology point of view, methotrexate, is it an anti-cancer drug or an anti-rheumatic disease modifying drug? With the law of the land, with the existing law of land, methotrexate comes under an anti-cancer drug in the anti-metabolite group. So you cannot prescribe methotrexate on your first consultation, on teleconsultation. But suppose your patient is already on methotrexate and you have seen the patient 3 months before as an in-person consultation, okay, you can continue with the prescription. This is an important point here. Whether you can continue with methotrexate in teleconsultation, it's going to be really a problem for us rheumatologists. I think the IRA should take it up in the next meeting or the EC meeting. And I think the doses, weekly dose of methotrexate up to 25 milligrams should be considered as an anti-rheumatic disease modifying drug. NSAID is hydroxychloroquine steroid, and all these are Schedule H drugs. Schedule H drug means these drugs can be, needs a legally valid prescription. And steroid was moved into this category in 2018. This you can prescribe on your first consultation. And so these other drugs like sulfasalazine, leflunomide, all these drugs are Schedule H drugs. If, it's better to avoid the first consultation, it's better to avoid these drugs. Once you are sure about your diagnosis, once you have documented evidence that this is the disease, okay, I can start with this medicine, then okay, you can go on with these medicines in the, teleprescription. But remember that you need to give or the counseling about all these drugs, how to take, what all things to be expected, and so and so. Biologics, I think it's better to avoid biologics as a teleconsultation. You have to insist on an in-person consultation because there are so many issues to be covered. And the guideline says that this should be some of the pattern of your prescription, but it doesn't insist that you have to follow this, but you have see that the registered medical practitioner name, qualification, etc. should be there, patient's name, the current date of consultation, etc. And remember, you need to record the complaints and relevant points from history, your examination findings, relevant investigations, and then your diagnosis and provisional diagnosis. All these points should be in the prescription. And then of course, the drugs which are prescribed in a capital letter, or if it is typed small letters, but the brand name, the pharmacological name should be there, and the dosage and everything, the duration should be very clearly written there, and the patient should also be counseled with the same. And these are some of our model prescriptions which we have issuing. This is what the patient get as an email. They can download. This is the prescription, what the prescription looks like. It is clearly say the diagnosis, relevant reports, and the medication. You can see that I have prescribed methotrexate for this tele-prescription, but here the patient was seen in the clinic by me earlier. Diagnosis certain, so that is why I continued with methotrexate. But if somebody asks, is this legal? Because anti-cancer drugs cannot be prescribed in a teleconsultation. Well, you have to settle that issue in a court, because at the moment we don't know. But looking at the guideline, I think if you are sure about the diagnosis, you can continue with methotrexate even during a teleconsultation. One other important point is prescribing medicine without an appropriate diagnosis provision will amount to professional misconduct. And remember, amitriptyline, prothiazide, duloxetine, tramadol, morphine, etc. should not be prescribed. And you don't need to follow the same format. You can write your own prescription form, but you can take a photocopy, scan, or digital copy and send it to the patient. That is legally acceptable. But there are some points that are not permissible. You can't insist on a patient, the patient who is willing to travel, you can't say, no, don't travel, like I can see you as a tele. You can't insist on that. And also the patient privacy has to be respected. And our Shanai published the first paper on teleconsultation rheumatology in India, and he found that switching to teleconsultation would be ideal for rheumatology patients especially during the COVID era. What we use, our hospital has come up with an Aster e-consult platform, and the patient and the doctors can download it in your Android phone, or you can also have a website form. And this is what I get in my mobile phone: the number of patients, appointment date, and whether you need to reschedule, confirm the appointment, like that. This is what I get on a desktop. So you can see the patient's name, the consultation time, and all I have to do is click here, start video call, and then I can start seeing the patient. I'm going to say, with the time constraint, I'm not going to insist on this, but this is what we see. You can see that monitor, and you can examine, you can look at the joints, number of swollen joints, tender joints, look at the elbows, the movements. You need to make a mental assessment, mental dash while doing this. Which are the joints affected, which any restriction of movements, all these can be assessed. I'm not going into the details of how you examine a joint at the moment, but remember, when you do a follow-up consultation, even before you see the patient, you have got the patient medical records. You have got the patient diagnosis. You know that what all medications he or she is on. You know whether the patient has got any disease-related complication. For example, in rheumatoid arthritis, whether the patient has ILD or not, and the other comorbid conditions like hypertension, diabetes, coronary artery disease, etc. And you also have the investigation reports just before your consultation. So even before you see the patient, you know these things. You know what are things to ask for. And you can concentrate on that point. And in that way, you can really make your teleconsultation very effective. I basically follow this. How are you today? If that first question, if the patient, I'm okay. That's fine. Doctor, fine. Then you don't need to spend on assessing disease activity. This is my experience. Then I don't ask so many questions because she is fine on your medication. So that's okay. But suppose the answer is not feeling good, very bad. You must elicit that history. Why is she not feeling good? Is it because of the articular symptoms? Is it because of other systemic symptoms? Or because is it part of a depression or something else? So you need to take on elicit that history until you sort out why the patient is not feeling good. And when you examine the patient during teleconsultation, you have to do a mental dash. You have to look at the number of swollen joints. You know the patient was. You don't need to ask the patient all these things, but you can do a mental dash and a dash 28, and you can decide whether the patient is in remission, mild, moderate, or high disease activity. At the same time, when you ask specific questions, you are seeing a rheumatoid arthritis and follow-up. You shouldn't miss an interstitial lung disease. You need to specifically ask for cough, breathlessness, etc. And remember, fever, loss of appetite, if they report that, these are red flag signs. Irrespective whether you know whether the patient, you are sure about the diagnosis, insist on an inpatient consultation for further evaluation. And same with the systemic symptoms. And all the newer medication, including alternate medicines, should be noted down. And you must conclude your the consultation in a way that the patient understands, okay, the consultation is going to end, and you should keep on asking, do you have any other doubts, or do you want to clarify any further point? And before you end your teleconsultation, make sure that you reach that stage, make concluding remark, so the patient knows that, okay, the consultation is going to end, and she or he can ask relevant questions or clear doubts at that point of time. New patient consultation, it's absolutely essential that you have to have a detailed history. And whenever you talk to the patient, you should keep on asking yourself, should I change this to an in-person consultation? You should keep on asking yourself, do I have a confident working diagnosis? At the end of your consultation, at the end of taking the history, you should ask you, do I have a confident working diagnosis? If not, change that to an in-person consultation. And before you write or prescribe medicine, make sure that you have a working diagnosis. What I do, I tend to discourage new patient consultation. And whenever I had, I always arranged investigation and followed up the patient for an in-person consultation. My personal experience, I mean, over the last 3 months, I have seen 503 teleconsultations so far, and it's slowly approaching 600 now. And all these, we are going through the hospital app, either through a website, and I also use WhatsApp video call when the internet issues are there. And the patients are given a signed prescription generated through the digital platform, and it's sent to the email ID. I have seen almost all the rheumatology patterns. These are the number of patients whom we saw, and these are the drainage areas. Basically, from 5 districts. I have seen one patient from Trivandrum, and 3 from Ernakulam, and 2 from Thrissur, and some patients from outside state, and a few patients from, UAE, like that. And we actually assessed the feedback from our 50 participants. So we asked, how was your experience? Very bad, very good, these things. And 43 out of 50 were happy with, they said very good or good. And the 7 patients, if bad, then we asked what were the reason. Most of them had technical issues because it was very difficult for them to get into the, get a booking. And, they were not very familiar with the technical aspects of this consultation. And that is why they felt that the experience was not good. And then how was your interaction with the doctor? I'm not making this up. All the 50 participants were happy with the doctor. Would you like to do it again? We asked. And actually 40 people said yes. But the other 10, they said they are happy, but they want to travel to the hospital. They want to see the doctor in person. And that is it. And we asked any suggestions to improve the system. All of them said that it should be user friendly. Like they find it very difficult, to book a teleconsultation. The process could be a little bit more easier. And it's all regarding the basically the technical issues. And look at the future. Now the National Medical Commission is going to come up with an online course, and they have clearly said that only those who have passed the online course will be eligible for teleconsultation. They're going to announce it, and you have to pass the online course within 3 years of announcement. And you are going to see a super spread of super specialists. Now, Shania can start franchise clinic in every district, and you can see all the patients in the state. And probably you may see a corporate teleconsultation. The hospitals may come up with the doyen in the field of rheumatology. They may be tied up with a corporate hospital, and you can have so many initiate so many consultations. But remember that you are going to see more and more medical legal cases, and new guidelines, rules, and regulations are going to come up. And it's our responsibility, IRA, that the methotrexate issue has to be sorted out, and you have to modify, you have to make up your own guideline, our own guidelines regarding the use of biologics and use of other medication. And you need to make sure that you get it into the attention of the National Medical Council. Of course, the association can take it up. And the take-home message is teleconsultation is here to stay. This is ideal for follow-up. And you need to be aware of the limitation of new consultation. And when you see a rheumatology problem, concentrate on the disease activity. Make sure that you are not missing a disease-related complication. You need to be aware of the drugs, drug-induced side effects, and drug interactions and comorbidities. Be aware of the limitations of online prescription. And it's never a substitute for physical consultation. Thank you.
Thank you, Remesh Bhasi, sir. As usual, fantastic such a new topic, but you have covered it through. One comment I would like to add is we have done lots of teleconsults, in thousands. So the problem what I face now is the patients are so accustomed to teleconsult. Even after 6 to 8 months, they refuse to come for a personal follow-up, and they may in future also demand that we would like to stick to teleconsult, even if this era ends and everything ends, because they are so comfortable with it. So that is one of the challenges we are going to face.
Yes.
Another doubt I had was, can we continue the biologics, sir? If somebody is on biologics, can you continue it?
Yes, definitely. If you have seen the patient as an in-person consultation, you can continue the same medicine, no problem. But to initiate on a first line new patient consultation, you need more guidance.
Another thing what we have done,
you counsel the patient, it's at the moment it's not a problem. But if it's going to be questioned in a court of law, then the issue may come. That's it.
yes, another thing what we have done, sir, because when we were sending prescriptions initially, there were a lot of transcribing errors because they were dispensed from the pharmacy wrongly, from a local pharmacy. Drugs were not available. So now we have linked the software with the pharmacy. So they, the moment we finish the consult, along with the prescription, the courier goes from the pharmacy to the patient's house. So that's the thing what we are doing now.
Yes.
I think it's helpful. Binoy Paul sir asked, how effective is teleconsultation for new patients? What do you think? What is your take for a new patient?
New patient consultation, if that is, I mean, I try to discourage new patient consultation, and all I mean, I might have seen, doctors, some of the doctors or doctor relatives I have seen as new patient. But the thing is, you should keep on asking yourself, are you confident about your diagnosis at that point of time? And do you think that a physical examination is mandatory to raise more information? So if you are okay with another, no problem in seeing a new patient consultation. And it is perfectly legal according to the new guideline.
Sir, are you recording your audio? That's what Binoy sir again asked. Are you recording entire consult for medical legal purpose?
No. We are not recording the entire consult, but the relevant points are being noted in the history. Everything, and we are keeping the record, and we are planning to keep the record for 3 years.
Another very relevant question is, can you continue duloxetine and tryptomer? If somebody is on duloxetine or tryptomer, can we give a repeat prescription for that?
I'm not sure, I mean, because this is new guideline, because we are not sure. But I think the patient is already prescribed that medicine as an in-person consultation, and you know the patient, that probably can be continued as an online consultation as well.
And this question was Dr. Akker from Mumbai. Another question he asked is it necessary to have the same consultation fee for online and physical consult? Is it a must?
Not necessary. You can charge your fee, and it is up to you to decide what you want to charge. And whatever the fees is legal, okay? So you can decide your fee.
Another very good question, sir. Do you think by doing telemedicine, the amount of investigation you order is higher than the physical consult? Because in physical consult, you become more confident of your diagnosis and order less test.
I believe that if you are going to see a new patient, you don't want to miss anything, and you will be ordering a bad fee investigation for medical legal purposes. So I think I agree with that. You may tend to, for a new patient consultation, it's likely that the investigations may go up, which you would have controlled if had it been an in-person consultation.
I would just like to add, sir, another thing what we have seen is those patients who are in remission for rheumatoid or lupus, they are the best for teleconsult, because unlike that's one of the things. And what I have noticed is we tend to use short course of steroids more often when you do teleconsult, because the moment they say increase pain, you don't want to take a risk. You give NSAIDs or steroids, but if you see in person, that use may decrease. That's my personal experience. I don't know how.
I agree with you. Yeah, I agree with you. I have done the same thing. I agree with you.
One of the things I think we tend to err on the higher side. We take on when somebody has pain. Thank you, Bhasi sir, for that wonderful lecture. And I hand over to Dr. Anup for the conduct of next session.
Thank you, Jason. Thank you, Shenoy, and thank you, Jason sir, and other organizers for this fantastic webinar. So, in the second part of this webinar, we are actually concentrating on diffuse systemic sclerosis, which is one of the most important, one most severe, challenging disease for every rheumatologist. So, there is tremendous improvement in immunological aspects and also the treatment aspects of systemic sclerosis in the last few years. And I think our colleague and a friend and Dr. Madan Mohan is going to talk on the last year in review, basic and clinical aspects of the systemic sclerosis. So over to you, sir.
I must thank the Kerala chapter of IRA, especially Dr. Jayachandran for inviting me for this talk. So I'll be discussing in this year in review scleroderma. So initially I'll be talking on the basic science. As we know, scleroderma is a CTD. The pathogenic features include immune dysregulation, endothelial cell dysfunction, and alteration in the extracellular matrix, leading to deposition of collagen in the skin and internal organs. MHC class 2 genes, especially HLA-DR-B1 and DP-B1 has been confirmed in predisposing to scleroderma. Non-HLA genes have been implicated, especially genes involved in vascular endothelial growth and hypoxia, autophagy, and NK cell regulation. Long non-coding RNAs are a type of RNA. This is defined as being transcripts with lengths exceeding 200 nucleotides that are not translated into protein. Downregulation of non-coding RNA 201 that regulates tumor proliferation and genes related to inflammation, vascular alterations, and fibrosis has been identified. This long non-coding RNA may be the link between scleroderma and cancer. Last year, there was some description of microRNAs related to cancer. So now it's not only the genetic linkage is being more coming out, is more becoming clear. The antibody which is usually associated is RNA polymerase 3, and now these genes are also being identified. A number of cytokines and chemokines have been linked to scleroderma. Upregulation of interleukin 18, 17, 6, CXCL4, the interferon regulatory factor 7, downregulation of a transcription factor related to plasmacytoid dendritic cells. So efferocytosis, this is namely the clearance of apoptotic cells by phagocytic cells. This is implicated in the pathogenesis. Scleroderma macrophages demonstrate a decreased efferocytosis capacity. Environment factors such as viruses, the human herpes factor, HHV6, and heavy metals like aluminum, cadmium, mercury, and lead contribute to the onset of disease. Adipokines may have a role in pathogenesis. Patients had higher concentration of resistin, fractalkine, and endothelin-1 and lower adiponectin levels. Impaired levels of these can influence endothelial dysfunction in scleroderma. Other pathogenic factors include alteration in the angiotensin 1, 2, angiotensin 1,7 axis, tryptophan, and its metabolite kynurenine. So this is a summary of the basic science. So I'll now go to the clinic science, which interests more the clinicians. So in this paper by Sobansky, phenotypes determined by cluster analysis. This paper was actually discussed in Pondicherry by Pooja Belaniete. So this is rather important because as we know, these cutaneous subsets may not show the heterogeneity of the disease. And definitely it is a heterogeneous disease. So what they have done is they have used clustering analysis, and it has shown that while some groups resembled the usual diffuse scleroderma and limited scleroderma, others exhibited unique features such as limited scleroderma patients with a higher rate of visceral damage and topoisomerase antibodies, which we expect in diffuse scleroderma. So there is a zero discordance. So this type of this study shows that our original concept that differentiating into only two types is rather imperfect, and this study and further classification may come into practice. So this paper is rather important. So it's not the usual subsets. So now what are the predictors of disease worsening in diffuse systemic sclerosis? So what they have identified is the age, active digital ulcer, lung fibrosis, muscle weakness, and elevated CRP are predictors of severe disease. So if you have patients, then you should be careful because these people are the ones who go for organ failure within a year. So this is again from the U-star analysis. So the modified Rotnan score has been now used. A fibrosis short-term progression there's a definition: increase of 5 or more than 25% within 1 year is associated with long-term decline in lung function, worse survival, and increase of all-cause mortality. So this is again from the USTAR database. In the last decade, survival of scleroderma has improved, and the cause of death related to internal organ involvement has drastically changed. So this renal crisis death has significantly decreased, and lung involvement, both ILD and pulmonary hypertension, represent the leading cause of morbidity and mortality in scleroderma. HRCT, as you know, is the gold standard in ILD. But now lung ultrasound is picking up, and it has been investigated, and B lines have been proposed as the sonographic hallmark of CTD-associated ILD. A positive correlation between lung ultrasound and HRCT with 91.2 sensitivity and 88.6% specificity has been described. So I think if you are using lung ultrasound, this is a very good modality. The first paper where I think I read where PET-CT is now used has come up. So it has been seen that positive ground glass opacity segments presents a clear 18 FTG activity, suggesting the existence of an increased metabolic activity potentially due to inflammation. So when we do HRCT, we cannot see fibrotic areas, but whether there is any inflammation, it is not. We are not able to make up. Although we think these ground glass segments may be inflammatory, so this PET-CT is now showing that these are actually inflammatory areas, and whether we can use steroids even in low dose in these cases requires further workup. The limited scleroderma may be progressive as the diffuse scleroderma, and this supports the inclusion of limited scleroderma patients in ILD trials, and they also may benefit from anti-ILD drugs. So in fact, all patients should undergo PFT and HRCT as the presence of ILD affects outcome. In a nutshell, all patients should be included. It is not that only diffuse should be included. So regarding, this is a very interesting paper which recently appeared in 2020. This is progressive interstitial lung disease in patients with systemic sclerosis associated ILD in the USTAR database. So this is from Zurich by Professor Distler and his colleagues. So they have found that this paper, I think everybody should read the original paper. Around 30% of scleroderma ILD patients experience progression during any 12-month period. And 67% of all ILD patients experience progression at any time over the 5-year follow-up. So they followed up patients over 5 years. And ILD patterns are very heterogeneous. So this is that most patients show both progressive and stable periods. So it's not that everybody is deteriorating. So there can be some periods of progression and then stability and then again progressing. Smaller changes in FVC, usually we take it as more than 10%, but even 5 to 10% may be clinically significant as seen in patients with the IPF. So in clinical practice, even a 5% decline should alert physicians, especially when multiple declines occur, even when not in consecutive periods. So this shows the importance of serially monitoring these patients. So from this study, what they have found, the strongest predictive factors for a FVC decline over 5 years were male sex, higher modified Rodnan skin score, and reflex and dysphagia symptoms. So this is this graph they have shown. And here, you know, it's not that as we see, usually in SSA ILD, lower FVC patients progress in a rapid phase. For example, less than 65% FVC, they progress. But they have now studied patients even with a higher FVC. And what they found is, in this curve, FVC improved. In some patients, it improves. And there is, in some patients, it is overall stable. But those with the decline, even they may not decline immediately. You know, for example, there is in this this line, there is an overall progression, no FVC decline for 12 months. And there are both periods of stability and improvement and periods of decline. So it's a slow form of decline. Here, actually, in this red line, you can see overall progression with FVC decline at 12 months. And with periods of stability and improvement at periods of decline. That means it is not, again, it is homogeneous. So there can be periods when it is stable and when there are periods when it declines. And there are certain category of patients where overall rapid progression with no periods of stability and improvement. That means this is a very heterogeneous disease. It's not that as It's not like as we think. So this shows the importance of serial, monitoring of these patients. A new pattern of ILD has been described. This is called pleuroparenchymal fibroelastosis, and this is defined as fibrotic thickening of the visceral pleura and sub-adjacent parenchymal areas of the upper lobe. This pattern is rare but associated with a negative prognosis. Another is combined pulmonary fibrosis and emphysema syndrome associated with high mortality and high morbidity, highly impaired lung function, and more frequently developed precapillary pulmonary PHD. Small airway dysfunction may be a feature of SSC-related lung involvement. We generally think of fibrosis, but this is also now becoming important, small airways. Impulse oscillometry combined with HRCD can be used to detect small airway dysfunction. So this you can discuss with your pulmonary colleagues. 1/3 of limited scleroderma patients had one feature of small airway involvement. Radiological features were detected in 25% of patients and occurred in the absence of underlying ILD, suggesting that peripheral airways may be an early target of scleroderma lung disease rather than a consequence of parenchymal architectural distortion. So we like to think of small airway again. It is not only the fibrosis, it can happen before. The small airways can happen even before. Nitrogen single breath out washout test for early diagnosis of small airway involvement has now been proposed. Scleroderma patients without detectable fibrosis may present with an alteration in gas transfer due to alteration in pulmonary vascular morphology. So even before fibrosis comes in, patients can have alteration in gas transfer due to endothelial involvement. And this may be the reason for the discrepancies which we see on 6-minute walk test sometimes. So we always talk of DLCO, but here now they are talking of DLNO, that is for nitric oxide. And this seems to be more sensitive, and both were correlated with CT measurement of ILD, but only DLNO was constantly reduced in all subjects with fibrosis more than 5%. That means this is more, this reduction is more in all the patients. So now coming to cardiac involvement, heart failure with preserved ejection fraction, that is diastolic dysfunction, is common in scleroderma. Multi-layer spectral tracking echocardiography. This is the this will use special software and use something called strain imaging, or more appropriately called myocardial deformation imaging. So this form of echocardiography will be more sensitive. Cardiac MRI is being more used. Myocardial fibrosis, the middle LV segments, and old age were predictors of heart failure. High sensitivity cardiac troponin T and NT-proBNP levels have been proposed as biomarkers for heart involvement. So what are the risk factors for mortality in systemic sclerosis? What they have found is male sex, low percentage DLCO, exercise oxygen desaturation, anemia, abdominal dyspnea scores, and baseline pericardial effusion are strongly associated with mortality. So you have to be careful with these patients. Renal involvement, although it has improved, there is importance of monitoring blood pressure, proteinuria, and estimated GFR. Presence of 3 or more of the following lab alterations: proteinuria, CKD, elevated ESR, thrombocytopenia, anemia, anti-Rho and anti-POD3 antibodies, and hypertension was associated with scleroderma renal crisis development with sensitivity 77% and specificity 97%. High renal resistive indices is indicative of renal involvement. This is measured by Doppler, and you can ask your radiologist. This is a Doppler in an intrarenal artery, and this is the difference between peak systolic and end diastolic blood velocities divided by the peak systolic velocity. Higher baseline RRI value is associated with mortality, cardiac, and renal worsening. So I think we should be asking, our radiology colleagues. GA symptoms, particularly reflux and diarrhea, are more common. Upper endoscopy is recommended in all patients. Hiatal hernia in limited scleroderma, correlation between ILD and abnormal esophageal motility suggesting double etiology due to disease activity and GERD. A high prevalence of esophageal symptoms and of high resolution manometric abnormalities have been described. However, there is no clear association. So now I will come to the treatment part. So what we do in clinical practice. So this is from an insurance database. And they found that 30% of patients received immunosuppressive treatment during the first year after diagnosis. 43% received hydroxychloroquine and 21% were on methotrexate. 46% were treated with corticosteroids, although we know the deleterious effect of corticosteroids in scleroderma. So this paper is very interesting. This is an experimental study on 21 scleroderma patients evaluating the in vitro effects of dexamethasone on cytokine production in peripheral blood mononucleotides. They documented a downregulation of several cytokines. So a previous study by the same group, they found that the methylprednisolone had a reduced effect on cytokine expression, suggesting that these two steroid molecules had a different effect, and there was resistance to methylprednisolone in scleroderma patients. So whether we could use dexamethasone in preference to methylprednisolone, this has to be seen. Cyclophosphamide is the standard treatment and reduces skin thickening and is used in ILD. The duration of its benefits after stopping is short, and hence the value of maintenance treatment. So this is maintenance treatment is a must. These results suggest that increasing the duration of ILD therapy may improve outcomes for patients with systemic sclerosis. This is from the this is a comparison of scleroderma lung study 1 and 2. So rituximab is used in scleroderma more and more. And this paper is from our Alkendu Ghosh from Calcutta. So they have studied 60 patients with skin and lung involvement, randomly receiving monthly pulses of cyclophosphamide or RTX, 1000 mg at day 0 and 15. After 6 months, FVC in the RTX group significantly improved, while it declined in the cyclophosphamide group. Moreover, rock and skin score improved significantly in the RTX group. Also, the safety profile was in favor of rituximab. So this study shows that the beneficial effect of rituximab. But in a later study, see, this study is from Annals of Rheumatic Disease. So the outcomes of patients with systemic sclerosis treated with rituximab in contemporary practice, a prospective cohort study. So they have studied around 254 patients. So there are points where patients treated with rituximab were more likely to have skin fibrosis involvement. Treated patients did not have significantly different rates of decrease in forced vital capacity or DLCO decrease. And actually, patients were on rituximab were more prone to stop or decrease steroid. That means it had a steroid sparing effect. Patients treated concomitantly with the MMF had a trend for better outcomes as compared with patients receiving rituximab alone. So this, whether MMF was working or whether rituximab has a real role, has to be really seen. So what they have concluded is rituximab use was associated with good safety profile in this cohort. Significant change was observed on skin fibrosis, but not on lung. However, the limitation of the study, this was an observational design. The potential stabilization of lung fibrosis by rituximab has to be addressed by a randomized trial. I think Shanai has done some work on this, and I don't know whether he is published in any peer-reviewed journals. I think this will be a real breakthrough. MMF in the scleroderma lung 2 study, the two treatment arms, that is cyclophosphamide, MMF, produced similar improvements in FVC predicted at 24 months with better tolerability and safety given by MMF. The significant difference was the DLCO percentage predicted and in a ratio of DL by VA, that is the ratio of DLCO to alveolar volume predicted. This decreased less during the MMF arm than the cyclophosphamide, suggesting a possible benefit of MMF in moderating the destructive effect of ILD on gas transfer. That is, again, we are talking of gas transfer. That means this drug is not simply retarding fibrosis, it has an effect on the vascular endothelium. A positive effect of MMF on pulmonary vascular remodeling has been suggested by its effects in a rat model of pulmonary hypertension. So it has got much more benefit. So this study, progression of interstitial lung disease in systemic sclerosis, the importance of KL6 and CCL18. So here again, what they have found is there is a higher baseline KL6 and CCL18 were more likely to experience disease progression despite treatment. This could be used to identify patients with a progressive ILD phenotype. Here again, what they found was those who were put on MMF experienced the greatest decline this compared to cyclophosphamide. So cyclophosphamide is proving to be a superior drug. So this paper is really interesting from arthritis rheumatology. Using transitional changes in high resolution CT to monitor the impact of cyclophosphamide or MMF or sclerosis related interstitial lung disease. So this is again by Dinesh Khanna group. So they evaluated over by HRCT, and their conclusion is interesting. Significant transition from both ground glass and lung fibrous ILD pattern to a normal lung pattern were observed in patients undergoing immunosuppressive treatment for SSC-ILD. That means even in patients who have fibrosis and ground glass, you can even get a normal lung. So this shows that, you know, the role of or the importance of maintaining long-term immunosuppression or putting patients on, you know, they can even get a normal lung back. So I think the, you know, the importance of long-term therapy must be emphasized. Dinesh Khanna's group has now studied IL-6, and IL-6 promotes fibrosis by activation of the transcription factor STAT3. So they have done this trial called Fascinate. This is the safety and efficacy of subcutaneous tocilizumab in adults with systemic sclerosis. So this was the first trial in 2016, and the second is an open label period of the phase 2 randomized control trial. So this was again published in 2018. So now they have gone for the phase 3 trial, efficacy and safety of tocilizumab in the focus trial. So what they found was the primary endpoint, which was a change in the modified Rodnan skin score, was not achieved. And what they found was a preservation in the lung function was shown. And these patients were all early active diffuse cutaneous scleroderma at risk of ILD. And in these patients, tocilizumab offered some lung preservation. So now all these studies, this study is by Dinesh Khanna has used subcutaneous, and it is now available in our daily practice. So what patients we can put in a tocilizumab in preference to rituximab? So this paper from Modern Rheumatology answers these questions. So this is a study, it's a Japanese study, and they have found this, the short disease duration, high C-reactive protein, low IL-3 and low CCL5 may represent SSCC endotype responsive to this form of therapy. So maybe a short disease duration, high CRP, these sort of patients, you know, are the best candidates for tocilizumab. So this is the latest paper which appeared recently by Dinesh Khanna's group. So this is they have used this is a interleukin 4 and 13 have been implicated in the fibrotic pathway. The IL-13 actually activates STAT6, and this causes the conversion of myofibroblast, a conversion of fibroblast to myofibroblast. So what they have used is a humanized bispecific IgG4 antibody. This is called romilumab. All these names will be initially be very difficult. And this binds and neutralizes IL-3. Patients with the disease duration less than 36 months, Rodnan score around 10 to 13, with or without immunosuppressive background, were randomized to receive 200 milligram of placebo for 24 weeks. Patients with the diffuse cutaneous scleroderma who were treated showed statistically significant reduction compared to those receiving placebo. So secondary outcomes were not met, although this antibody was associated with a decline in FVC than placebo. So vasoactive treatment. From the Decipher study, it has emerged that 33% with previous or current digital ulcer were treated alone with calcium channel blockers. Iloprost, a synthetic analog of prostacyclin, PGI2, is the first choice for the management of severe RP and duodenal ulcer when oral therapy fails. Riociguat is a soluble guanylate cyclase stimulator approved for the treatment of pulmonary hypertension. A multicentric study evaluated this in digital ulcer burden, and they found that after more than 16 weeks of therapy, there was complete healing of digital ulcers. So this drug, you know, besides using calcium channel blockers, tadalafil, you know, can be tried in our patient, and this drug is available. Vasandan, as you know, is available for a long time. Over 1 year follow-up, they have found improvement in Raynaud's phenomenon and the digital ulcer related symptoms, and also improves the functional outcome. Antifibrotic therapy. This is recently coming to India, nintedanib. This is a tyrosine kinase inhibitor approved for IPF. And they have studied 576 patients, 1:1 randomization, both diffuse and limited cutaneous scleroderma patients. and about half was taking MMF. At 52 weeks, there was evidence of a lower rate of decline of FVC in the group. There was no effect on skin fibrosis. Presence of limited cutaneous scleroderma patients as well as the use of MMF might constitute a bias in this trial. This drug is very promising as it interacts with the ATP binding pockets of many tyrosine kinase receptors, including platelet-derived growth factor receptor, fibroblast factor receptor, and vascular endothelial growth factor receptor. So it can reduce lung fibroblast proliferation. It can reduce extracellular matrix molecule expression and transition of fibroblast to myofibroblast. So finally, we are coming to autologous hematopoietic stem cell transplantation. So various studies are available, and this is effective in severe and rapidly progressive form of the disease. Regarding cutaneous and pulmonary involvement, what they have found is when you transplant bone marrow derived CD34 selected cells, this is more effective and experience a better reduction in the Rodnan skin score and FVC, and its duration was longer. So it's possible that CD34 cells prevent the reinfusion of autoreactive T lymphocytes. So the CD34 is a glycoprotein expressed on the surface of progenitor cells and small vessel endothelial cells. The last paper on transplantation, this paper is interesting because following transplantation, after myeloablation followed by autologous stem cell transplantation normalizes systemic sclerosis molecular signatures. They studied patients in the SCOT trial and found that marked interferon, neutrophil, and inverse cytotoxic NK cell transcript signatures were corrected by HSCT. So this gives the molecular base for the immune system resetting power. So just like the whole immune system is reset. So now I am coming to the end part. So here again, they have now here used adipose stem cell, and they have used for lipotransfer in the surgical intervention proposed in the treatment of orofacial fibrosis. This is a common problem, and patients become malnourished. And I think you can ask your plastic surgeons. These patients showed improvement in all domains of mouth function. Aesthetic and psychological benefits were seen. Low-level laser light therapy. So this has been used in diabetic venous ulcers. So here, it has been now tried in digital ulcers, and it's actually to increase local perfusion, oxygenation, and angiogenesis. Then in primary and secondary Raynaud's, you can use carbon dioxide hand immersion. So, this is historic notes, and I don't know whether you have all seen this. So this is the, first, the title page of the book by the man who first described, scleroderma. He's from an Italian from Naples, Carlo Curzio, in 1753. This is the title of the book. And this contains the first known detailed description of the disease resembling scleroderma. So here he wrote, the 17-year-old patient was having extensive tension and hardness of her skin all over her body. Curzio managed the case with bloodletting, warm milk, and small doses of quicksilver. So in fact, he is right, because he was doing bloodletting. Now we are in hematopoietic stem cell transplantation. So the whole problem, he knew from that day. So I think this person, I think everybody knows. This is Gerald P. Rodnan, and we are always talking of the Rodnan skin score in scleroderma. He's a rheumatologist from Pittsburgh in the United States. So this is again a memorial plate in Naples, and this plate commemorates the first description of scleroderma, and this was signed by Rodnan itself. So this, I was happy to attend one of these USTAR courses. Most of the European research is from this USTAR consortium or rheumatologist. And I think, I think many people do not know certain thing about this, because you can attend this course, and if you pass the scleroderma course of EULAR, you will get a free registration for this. I think young rheumatologists, this is one chance to attend this course. And if you are able to pass the exam, they will give you a free registration. Only then you book the hotel and the air ticket. So the registration itself will be around 600, 700 euros. And this is a very good crash course. And all the European rheumatologists, only I think one or two people we are actually seeing in India, like Chris Dendon, but most of the European rheumatologists who are working with this U-Star, we really don't see them in India. So this is a crash course, and I recommend all junior rheumatologists, especially trainees, to attend this, U-Star course. But the best thing is to pass the exam, ULAR exam. So now coming to ultrasound, we have now started. I am doing ultrasound in my clinic. And for patients with scleroderma, the investigators suggested the high frequency, more than 20 megahertz sonography is a feasible method for measuring skin thickness and stiffness. So our only problem is I don't have this high frequency probe, this 24 megahertz probe. I am only having this 8 to 18 megahertz probe. So I think once, of course, the probes are the most expensive parts of the ultrasound machine. So I think with this, I conclude my talk, and I thank the Kerala chapter for, especially Dr. Jayachandran, for inviting me, and we will welcome some questions for this session. Thank you.
So is there any, apart from one of the other thing is rituximab trial versus cyclophosphamide, which was published from Kolkata again. I think that is one of the contributions of Indian to the scleroderma research.
I think you have contributed one paper, I think.
We have a paper on cyclophosphamide versus mycophenolate. We have a couple of papers.
Rituximab, you don't have a paper? I thought you had.
I didn't publish that. Before that, the randomized control trial from Parashar Ghosh group came, which is again showed that.
I think you had a paper. I remember one paper in with the, Dinesh Khanna had edited. I think. What was it? That was on rituximab, right?
No, it was cyclophosphamide versus mycophenolate again.
Okay. Okay.
So we had shown that both are equally. It's a retrospective study.
Okay.
I think so. We are actually running short of time. 9:16. I hand over the mic to Jayachandran sir for concluding the session. Thank you.
Thank you. That was a great session. We had very interesting 2 talks. First by Dr. Remesh Bhasi on telemedicine and rheumatology, which is very important. And secondly, we had a very interesting session on scleroderma, updating the recent papers in last 1 year. So I thank Dr. Ramesh Bhasi and Dr. Madan Mohan for kindly inviting our invitation and presenting the topics. I also thank Dr. Shanai and Dr. Anup, in spite of their busy schedule, chairing the session very well. And finally, I thank all the delegates who attended the function, and also the IPCA laboratories who sponsored the session. Thank you all. Do attend our next webinar, which will be on the first Sunday of every month. Thank you all once again.